Good morning, good afternoon. Good morning, good afternoon, wherever you're joining from. Thank you for joining the June edition of the Get webinar series. I hope you can hear me. Okay, today we'll be discussing the WHO Pandemic Agreement, Advancing Global Equity and Preparedness for Future Health Crises. Let me apologize on behalf of the Chief Operating Officer, Dr. Ayodotun Babatoye, is unavoidably absent as is currently engaged in another meeting. In that regard, I'll be representing him and I'll be moderating this session. My name is Faith Omalade Adebayo and I'll be your moderator for today's session. So once again, good afternoon, good morning, good evening, ladies and gentlemen, wherever you're joining from. Thank you for attending the June edition of Get Webinar Series hosted by the Global Emerging Pathogens Treatment Consortium in collaboration with Wiley and Health. So this topic is very important and it's a timely discussion which comes with the need, with the heels of the recent adoption of the WHO Pandemic Agreement, which is a landmark commitment of over 120 countries to collectively improve global pandemic preparedness and ensure that no one is left behind in the face of future health crises. So today we'll be examining the agreement provision, reflect on its implication for Africa, and we'll also explore how our continent as a whole can be a beneficiary and as also a leader in the global health security space. So we are privileged to join us today, a distinguished panel of experts. And before we begin, I would like to read a few housekeeping rules. Kindly use the question and answer box for your question. And please introduce yourself in the chat box to let us know wherever you're joining from. If you're joining from Asia, from the US, the United Kingdom, Pakistan, wherever you're joining from, so we can get familiar with you. And thank you so much. And this session will also be recorded and will run for approximately 2 hours. The recorded session will be available on our YouTube channel. And also a participant certificate of participant will be shared to all our participants. Once again, I deeply appreciate our speakers. Thank you so much for joining, Mr. Boniface, Dr. Jennifer Nuzo, and Ms. Vivian Iekazu. So right now, I'll be going into our first speaker. But before I go ahead, I would like to introduce our first speaker by reading his biography. Mr. Boniface Abano, I apologize if I have pronounced that wrongly, is the Program Manager for Global Health Security Unit in AMREF Health Africa, where he oversees pandemic preparedness, prevention, and response interventions. He also serves as the team lead for the continent-wide Africa CDC MasterCard Foundation, supported Saving Lives and Livelihoods project in the Southern, Eastern, and Western Africa region. Boniface is a seasoned public health professional with over 34 years of work experience, where 24 of those years have been spent in the health development sector. He holds a master's degree in public health, an honor degree in social behavior studies in HIV or AIDS, and also a bachelor's degree in English and communication studies, and several other professional certificates. Boniface has been with AMREF Health Africa for the past 16 years, serving in diverse roles such as regional head of programs, country manager, and head of AMREF Africa, Southern Africa Regional Office. Thank you so much, Mr. Boniface. And before I give the floor to Mr. Boniface, kindly share this link to every of your colleagues and friends. Tell them that we are live and they can now join the webinar. Mr. Boniface, it's a pleasure to have you on board. Thank you very much. You now have the floor.
Thank you, Jennifer, and greetings, everyone. And thanks again for the invitation and that generous introduction. It's good to be here to share a few experiences from our perspectives in this side of the continent. I was a bit scared that I'm the first speaker, and I just landed deep in a rural field in Zambia. From Lusaka just like 30 minutes ago, but I'm privileged that I managed to get connectivity. I'm sitting somewhere outside the airport here. So I'm hoping the internet will be kind enough to sustain me through this presentation in the next few minutes. I have a few slides to take us through, and I will endeavor to speak as much as I can, so that we maintain time. I'm not sure, it seems my slide is not moving. Let me try and do this. Confirm, Jennifer, if I'm on the first slide, which is a brief about AMREF.
Yes, we can hear you, or we can see your screen.
Okay, great. So maybe just a quick one. I just thought I should just give a background of the organization that I work for. AMREF is a public health international NGO founded in 1957 as the Flying Doctors of East Africa. We are headquartered in Nairobi. That's where our international headquarters are. And annually, we reach over 10 million people directly with a number of services and programs. On the right side of the screen, you'll see the presence, physical presence in those green areas, including in West Africa, the Senegal, that's where our West Africa hub is. But the yellow part is where we have programs through partnerships, ministries of health and others in and out. The brown circulated blue star is where our headquarters in Kenya, Nairobi is, which also serves as a venue for our AMREF International University and the Flying Doctors. So briefly, we do have quite a mature and extensive global health security program in the organization, which is really anchored on 4 pillars: community health system strengthening, disease surveillance, laboratory diagnostics, and also working with the National Public Health Institutes and other CSOs. So now, I thought as the first speaker, maybe I'll do a bit of academics, but just as a disclaimer, the bulk of my discussion will really be on experiences shared. There will be no epidemiology, core hard science here, more of experiences, and I will just zoom through and a few of those based on our topic, the issue of pandemic equity and pandemic preparedness. So the International Institute for Social Change has been generous enough to, I think most of you could be familiar with this very popular image trying to distinguish between equality and equity. Briefly, equity is everything to do about fairness, impartiality, and maybe more directly to ensure that everyone gets whatever they need in order to improve the quality of their situation. And in the context of health and pandemics, it's really access to life-saving services, commodities, information, and all the like. So you will see that when you talk about equality, it means providing everyone with the same package in the same way. Yet equity means looking at the different dispositions of individuals, be it in society, in a country, in a region, even in the global space, to ensure that for everyone, like we are seeing in this image, for everyone to have a view of this game, it means you look at each person and see what it needs for them to come in. So you will see that the elderly gentleman on the left side of the image, because of his vertical disposition, he doesn't need to be enabled at all. And the older son there needs maybe 1 block, and the smallest one will need 2 blocks, so that everybody else has that equity. So I thought it would be critical for me just to remind all of us about that, what we are talking about when we're talking about equity in this space. Now, again, just a bit of really anchoring the discussion in terms of the perspectives from the World Health Organization, what their view on equity in pandemic preparedness. We all know that health is a fundamental human right in its own right, and equity then can only be achieved when everyone else can access, can also realize their potential and well-being given the services that are available. So it means we are trying to remove all unfairness, avoiding any issues or taking all those remedial efforts which makes people be able to at least to access services as much as they would like. And in this case, we always look at some variables like socio-economic, demographic, geographic, and even other dimensions like sex, gender, ethnicity, and many others. And now when we look at the just approved or adopted pandemic agreement, which was at WHO at the World Health Assembly recently, you will see that equity is already sounded in the introduction chapter, which is chapter 1. And if you look at Article 3, as part of it, there's a whole list of guiding principles there. So the first one really speaks directly to say, equity must always be at the center of pandemic prevention and preparedness across, be it between states, across the international regions, within countries, even at both local and national levels, if you zoom into each country. So equity must always be there. And they emphasize in that document, the newly approved agreement, that equity is not just limited to those issues of unfairness, but it also really ensures that it's timely, there's quality access, it's affordable. And for the purpose of this discussion on my part, because it's a whole broad of issues, really, when you look at about us being prepared for the pandemic in an equitable manner. But I'll just focus my discussion largely on issues of products, which includes life-saving medicines, vaccines, and the like, medical services, but also the issue of information. But you can think about all issues around local manufacturing, in terms of distribution, in terms of social protection. Those are many others, which I hope maybe they can be unpacked in the discussion center. So for the purposes of this discussion, I will just zoom in a bit on the chapter 2, which really is the one that lists all the articles in the pandemic agreement and how they really pronounce on equity. So to start, I'm just going to use maybe 2 really examples about the recent outbreaks in the region. Particularly, we do work as AMREF in Southern Africa, West Africa, and East Africa largely, but we do touch other parts of the continent, particularly Central Africa in and out. But for COVID-19 particularly, we had a privilege to assist 33 countries to deploy and administer vaccines, of which about 25 million were administered across the 33 member states through the efforts of the projects that AMREF had with several other partners, a lot of foundations really who came on board, the World Organization and Africa CDC. So, but really, when we look at equity, I don't think there is any better example that can really stress the importance of equity other than really the issue of COVID-19 vaccination. The experiences were painful. We all know it. I know it's a tired statement, but we remember how most of the low-income to middle-income countries really struggled to access vaccines because, number one, the issue of really the continent not able to manufacture its own vaccine. So we had to join the queue from the back in a way. And despite our fragile health systems, which on their own, now imagine with a pandemic like COVID, we saw how that happened. But we also remember that at the time then when the vaccines now became available, so when you think about equity and you go back to that picture that I showed earlier on in the slides, we are saying this is where the world now with this new agreement must try and look at the needs of each and every human being in terms of the country, but also globally, the communities. How do we collaborate together to ensure that no one is left behind, no one is made to join the queue at the back, but maybe we try to have equal access to, if equity is to be achieved. We remember that in the case of COVID-19 vaccinations, when the vaccines finally reached the continent, a lot of them were near expiration, with a very limited shelf life, and we know some were destroyed. Stories made headlines in the newspapers where even people thought maybe the people were not grateful because how will they even have a ceremony to destroy vaccines? We saw that in Malawi and other places, but this was the reality of the situation on the ground. Again, we realize that maybe again with complacency setting in, lack of knowledge, lack of actually scientific evidence to really prove the issues of sustained vaccination. We saw uptake when vaccines were becoming largely available, uptake became an issue. First, it was access, but then when they were available, we were confronted by poor uptake. And largely, because our health systems were not designed in such a way that they will be able to build and generate that public trust on the vaccines. Complacency setting in, we didn't have enough evidence really to demonstrate. Instead, we saw how the anti-vax movements came up with all sorts of theories and alarming statements really to dissuade people from access vaccine. Again, when you look at this issue of access, of equity in that context, you realize that information and education is a key issue if you are deploying vaccines to really tackle an outbreak of a disease of magnitude of COVID and others. Again, you realize that when we look at the socioeconomic status of different people, again, we realize those parameters of age, issues of poverty, issues of the last mile distances coming in again to impact the whole issue of outbreak. So we are now looking and seeing closely how this new agreement, which has just been agreed, will address these kind of issues. Our work, our data on its own, our data management systems, which is the information access that I spoke about, is quite compromised. Our health systems, again, when you look at the issues of capacity, be it in cold chain infrastructure, human resources for health, whether it's numbers, it's skills, we still find a various huge discrepancy between maybe higher middle income countries. When you look at even the issues of per capita ratios between health workers, how many people per doctor do we have in most of our African countries compared maybe to countries like maybe the Scandinavian countries, which are quite well invested when it comes to health. Look at the per capita expenditure there. It's again, issues of equity come on board. How then do we ensure that everyone else is brought on board if we are to really attain the issue of equity, particularly when there's an outbreak? We look at the issues of regulatory measures, be it in manufacturing, be it even in approval of new options, be it medicines, be it vaccines coming on in the board. The process of approval, again, take a long time and they're tedious, mixed again issues of cost and all the like. Again, this is just not just about COVID, but we look at even, I'm just going to show you now. We also had an experience with Mpox. As AMREF, we managed to get into DR Congo, into Burundi, trying to assist particularly on the diagnostic aspect. And again, we realize quite a lot of challenges in the context of that Mpox outbreak, where firstly, just the issue of understanding and appreciation, what are the drivers of driving, fueling the spread of Mpox, and in certain particular group, the data was so limited. You wouldn't tell in terms of which population groups are more vulnerable than the others. And we saw pregnant women, maybe people of commercial sex workers and all the like being most vulnerable. And then again, this fuels stigma, and stigma on its own drives discrimination and it drives people underground, and then equity is thrown out through the window. So the issue of behavioral research when we are tackling epidemics, outbreaks, is quite critical for us to understand the human aspects of drivers of some of these diseases. Infodemics is bad. It was actually quite massive in Congo, where it was thought like maybe this disease is just for men who have sex with men and the like, it's just for commercial sex workers, until it realized that it does not really choose. But of course, there are people already who are vulnerable, people with compromised immune systems and the like. We saw again lack of knowledge about the benefits of integrating our responses to epidemics, outbreaks. Particularly, you would have seen that we could have easily used existing programs, HIV, TB, AIDS programs in the world to reach those key populations to manage that. Issue of detection, I've already spoken about how we saw the issue of just collecting samples, just to remember mpox, we had to deal with classifying whether it's clade 1A, it's clade 1B. For you to draw a specimen deep down in Goma, in the bush, and then even the storage particulars of those specimens, by the time it gets to the laboratory, it's 36, 48 hours at the nearest point. It's already compromised in quality and you don't get the right results. It means, again, we are not able to do proper case management under those contexts. Again, equity goes through the window. I can't speak enough about the issues of epidemiology and surveillance importance. We saw in that mpox issue, the issue of what are the transmission dynamics country by country. To make even things worse, we saw a lot of issues on cross-border management, information sharing. Hence, we ended up having cases spilling over in Uganda, into Kenya, and even into Tanzania, and managed because even information sharing is compromised. There are areas where it's already, some of these pandemics are already endemic, but again, we don't seem to be in a position where we're able to use information and experience to manage the spread. And then just to quickly go, as I go towards the pause here, we now zoom now into what exactly is contained in the pandemic treaty, in the global pandemic treaty, when it comes to help us to fight that equity. Again, if you look at the Article 6 particularly, it speaks very, very directly to every party, and by each party we mean the countries, member states, that they must, and we should underline that word, ensure that enough resources are at their disposal. They take appropriate measures to develop, strengthen, and maintain their own health systems which are resilient. They ensure that we have strong primary healthcare systems. And then it's only then that we can really say we are able to account for equity broadly. Otherwise, we continue having clusters of the haves and the have-nots, or those who can access and those who cannot access, and it won't help, especially in a context where some of the epidemics are communicable. It means they can easily be transmitted. They will know no border, they will know no boundaries, they will know no age, and they will just hit everyone. So we need that all-encompassing health system anchored on strong primary health care. Again, the treaty calls upon every member state to ensure that they take appropriate measures based again on laws that resonate with the needs of each country to develop, strengthen, and sustain better systems, including infrastructure that I spoke about all. So when all these, when each member or each party at their level at least make full commitment to tackle these things, we are sure that we can now be able to talk about equitable access, particularly to services, to care, even the routine, as I say, essential healthcare services. The issue of cost effectiveness is critical again, especially when you look at the supply chain management. I spoke about the whole issue of compromised cold chains in terms of vaccine deliveries, which I can speak very closely to. I spoke about the issue of laboratories and diagnostics capacity. It's very, very critical for each, at least, party to make sure that this is available and it's well spread and the turnaround times are minimized. The results are confirmed. Otherwise, if we are not able to detect, confirm, we will not be able to do proper case management of these issues. Social behavioral science, I've already spoken about it, including community engagement, risk communication. These are really, really critical. So in conclusion, now I can say that if we are to achieve equity in this pandemic treaty, we need a health system which is ready before, during and even after an outbreak or even disasters, let alone. So in summary, in my submission, I just want to share with the colleagues here that the pandemic is very clear in terms of in chapter 2. It says the whole of chapter 2 is really anchored on the issue of how do we achieve equity. And then you look at those articles, each one of them is broken down very nicely, explaining exactly what needs to be done. Article 4 in terms of surveillance and prevention, One Health, research, the health workforce, the issues of diversity and geographies, local production and manufacturing, which is a big agenda, technologies in terms of cooperation, the big animal in the room, the whole issue of pathogen access and benefit sharing, where countries or member states should agree at what point do they access the benefits of everything coming out of research and innovations and development, supply chains and logistics, procurements, the issue of community engagement, government to society, communication, international cooperation, very, very critical. And we already know that we have a number of countries either who abstained to sign off in the current agreement, and there are those who really just did not want to even commit. So that on its own leaves a question mark in terms of whether are we able to achieve this global equity that we are talking about. Sustainable financing cannot be overemphasized, and hence, we are talking even about the push and drive, even the African Union at this side of the continent through Africa CDC. They are really talking about domestic financing and resourcing as much as possible without really saying discarding international funding. And we've seen the trends, development in the traditional donor money sending countries where the nationalistic approaches again are coming, I think, to impact severely on this initiative on equity. So I think I'll stop here and we can discuss as when you go, but I thought maybe I should just frame being the first one to come on board, and hopefully other colleague speakers can pick up here and take it through. So thank you very much, and I'll stop here. Thanks.
Thank you very much for that beautiful presentation, Mr. Boniface. We are very grateful for those beautiful insights. You mentioned a few things that equity must be the center of pandemic prevention, which I believe has been agreed. And you mentioned the painful COVID-19 experience must not happen again. Also, we also had the mpox outbreak. So all this has to be done, and all strategies, all measures has to be put in place for us to effectively implement this agreement. Thank you very much, sir. Please feel free to share your question in the Q&A box, and we'll be returning to them during the open discussion. We also want to apologize. We got to know that some of our participants are having difficulties joining the webinar due to the error message of this link is invalid. We sincerely apologize for that. Please share the link to your colleagues now. They can join using this new link. You can find the events link right underneath the participants box. So right now we'll be moving on to the second speaker for the day, and we have in our midst Dr. Jennifer Nozo. And before I officially give her the floor, I would like to go through her biography. Dr. Nozo is a professor of epidemiology and director of the Pandemic Center at Brown University School of Public Health, and she's an epidemiologist by training. Our work focuses on global health security, public health preparedness and response, and health system resilience. Together with colleagues from the Nuclear Threat Initiative and Economist Impact, she co-leads the development of the first ever Global Health Security Index, which benchmarks 195 countries' public health and security financing, public health and healthcare capacities and capabilities, their commitment to international norms and global health security financing, and socio-economic, political, and environmental risk environment. She also founded the Outbreak Observatory, which conducts, in partnership with frontline public health practitioners, operational research to improve outbreaks preparedness and response. Prior to coming to Brown, Dr. Nozo was an associate professor at the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins School of Medicine. She was also a senior scholar at the Johns Hopkins Center for Health Security. She is an elected member of the National Academy of Medicine and the American Academy of Arts and Sciences. In addition to her scholar work, Dr. Nozo regularly advises national government, for-profit and non-profit organizations on pandemic preparedness and response, including COVID-19. She was appointed to serve on the advisory committee to the director of the U.S. Center for Disease Control and Prevention, July 2025. Previously, she served as a member of the U.S. Environmental Protection Agency's National Drinking Water Advisory Council, NDWAC, and the NDWAC Water Security Working Group. Dr. Nozos regularly engages with media to educate and inform about emerging health security trends. Her articles have appeared in the New York Times, the Washington Post, USA Today, Fox News, Politico, The Hill, and the Boston Globe. She was featured in the Debunking Borat, a television series on Amazon Prime Video, and her work was featured on Last Week Tonight with John Oliver. She served as COVID advisor for the Borat subsequent movie film. Dr. Onozo received a Dr. PhD in epidemiology from the Johns Hopkins Bloomberg School of Public Health, an SME in environmental health from Harvard University, and a BS in environmental science from Rutgers University. Thank you so much, Dr. Nozo, for being a part of this webinar. You now have the floor.
Thank you so much. I'm sorry that biography was so long and everyone had to hear it, but I very much appreciate the warm welcome, and I am deeply honored to join you this afternoon. I think it's afternoon for most people. It's still quite early here today. I'm trying to share my slides. Can everyone see? Yeah. Hopefully you can. Thank you. This was a really excellent conversation starter, and I think I'll pick up on many of the themes that we're just hearing about. For me, as someone who has worked as an epidemiologist, I actually got my start in epidemiology working for New York City, working as a public health epidemiologist in New York City. But I've spent my professional career largely focusing on issues around outbreak, epidemic, and pandemic preparedness. And yet in all of those efforts over the last 20 plus years of my career, nothing prepared me for this site that we saw during COVID-19, which is a very empty New York Times Square. If you've been to New York City, and if you've been to Times Square specifically, I'm sure you may have seen it on TV or in movies, it is a very packed place. It's hard to walk through. There are so many people at all hours of the day. Seeing it empty in COVID because of the lockdowns that happened was just an emotional stunner for me. For me, it was the moment when I thought we got this wrong, because this shouldn't have had to happen. It shouldn't have had to come to this. Obviously, we've now lived through COVID 5 years ago. I think everybody is quite aware of everything that happened. I think one of the things that I feel most concerned about is how quickly we're willing to turn away from scenes like this and pivotal impacts like this in hopes that we won't have to deal with it again. I hear a lot comparisons between COVID-19 and the 1918 influenza pandemic that was called the Great Influenza. And those comparisons are apt at some level because the 1918 influenza pandemic was a truly world-changing event. It had very large tolls. In some instances, people just compare rough numbers of deaths between COVID-19 and 1918, just showing you some United States figures here. You might be tempted to conclude that COVID-19 was worse than the 1918 influenza pandemic just in terms of recorded deaths. There's a number of problems with that comparison, including the fact that probably recorded deaths were not so great in 1918, but also the size of the world's population is much larger today. So historically speaking, 1918 still ranks as one of the most deadly disease events in modern times. But I think it stands out for us as an evidence of, as bad as COVID-19 was, it isn't necessarily the worst that society may endure. The other challenge that I experience when people talk about 1918 or they talk about COVID-19 as a once in a century pandemic is many people who don't understand statistics, and I'm sure that's not this group at all, but they'll conclude, well, if it's a once in a century crisis, because 1918 happened a century ago, then we are probably good for the next 100 years. That is not how statistics works. With independent events, the timing of one does not influence the timing of another. So we have absolutely no idea when the next pandemic will occur. We know that they occur regularly. We have absolutely no idea how bad they will be. It could be like COVID. It could be like 1918. It could be worse. It could be milder. We just simply don't know. But not knowing shouldn't be an excuse for not preparing. Really, when we talk about events like this, we have to acknowledge the extraordinary impact that they've had, not just in terms of the numbers of people that have died, but in its abilities to set back progress on a number of important health fronts. Historic declines in life expectancy across the globe. No country emerged from COVID-19 unscathed in terms of these impacts. We also know that the impacts of events like COVID-19 and other pandemics, other big epidemics, even some outbreaks, they are not limited to the people who get infected and die from that pathogen. We know that they have impacts more broadly on the health system. We know that the interruption of preventative services and other treatments contributes to a loss of life and a loss of life expectancy that has nothing to do with the pathogen itself, but everything to do with the chaos and disruption that the pathogen causes. And then there are all these other categories of harms, the social harms, the economic harms, the political harms. I would argue that we are still sorting out what those harms of COVID-19 pandemic are, but I think we know that they're profound. All of us who have lived through it have seen them firsthand. I know for me personally, I have, as a mother of 2 children, having seen my children not go to school for more than a year, those harms were very easy to see. As you know, we are no longer in the COVID-19 pandemic emergency, and that is very much a good thing. The emergency has been ended, absolutely. And here's the official tweet from Director General Tedros indicating that this is very much welcome news. But one of the things that I sort of deal with in speaking to people is when people see this and hear this, they think, okay, good, and now I can just not think about these issues anymore. But we know that ending one emergency does not end all future emergencies. If we want to get to a place where we don't have to talk about the threats that these emergencies can pose, we need to do 2 things. We need to either eliminate hazards, or we need to reduce our vulnerabilities to them. And when I try to make that point to people, I find it's helpful to compare it to something they can see. The problem with infectious disease threats is that they're often invisible unless you're personally experiencing them. But we have data from the natural hazards world, and here's just something from where I live in New England, part of the United States, showing that what we used to call 100-year floods, we used to think they happened, every 100 years or so, are now happening on order of every 1 to 30 years. And when I tell that to people, they nod in agreement because they have seen these floods. They know that these floods are happening more and more frequently. They feel like every time they turn around, there's another devastating natural hazard occurring in their communities, disrupting life and harming health. We see the same data when it comes to infectious disease threats. So I tell people, if you feel like you're hearing about more things in the news, more and more outbreaks that are occurring, more and more stories about what's happening across the world, That is because there are more and more things happening across the world. The frequency with which we are seeing outbreaks of new infectious diseases is increasing, even when we adjust for differences in surveillance. There are more outbreaks happening now than there used to be. So if we are concerned with reducing the risks that these events pose, again, learning from the natural hazards world, what we have to do is either prevent the hazards, stop the outbreaks, prevent the outbreaks, make sure they don't become epidemics or pandemics, or I would argue, and reduce our vulnerabilities to them, reduce the collective societal vulnerabilities to them, such that if they happen, we are resilient in the face of them. We can manage them without unnecessary loss of life, unnecessary disruption to society. So now I'm going to turn my attention to what we can do on that front. So how do we prevent hazards and reduce vulnerabilities? And I'm mostly going to be talking about reducing vulnerabilities, although to some extent preventing hazards. It's hard to prevent outbreaks. It's probably easier to contain outbreaks so that they don't become epidemics, but it doesn't mean we shouldn't try to prevent outbreaks from happening in the first place. Now, as I mentioned in my bio, one of the things that I work on is the Global Health Security Index. And this was something that we first published in 2019, and then we published again in 2021. And one of the things we found when we looked at 2019, so initially at the start of the COVID-19 pandemic, there was an observation that some of the arguably best prepared countries in the world, the countries that scored the highest on the Global Health Security Index, seemed to be doing the worst in COVID. They were experiencing the most cases and the most deaths. It's not really an accurate way to look at the data because those data are very much tied to the capacities that countries have in order to diagnose infections and to determine cause of death and to report cause of death. Those capacities are the things that the Global Health Security Index measures. So you would expect to see countries with more capacities, with more abilities to use those capacities in order to identify cases and deaths. A fairer comparison involves probably looking at excess deaths, which are less dependent on diagnostic capabilities, and then making sure we adjust for the fact that age differences in countries probably makes a big difference in terms of how many people would experience severe illness and death. And when we do that, we find that better prepared countries tended to do better in terms of COVID-associated mortality. Now, not every well-prepared country did that, or I don't even like to use the word well-prepared, despite having just said that. Not every country that was considered better prepared fared well during the COVID-19 pandemic. And a giant outlier is the United States. The United States does poorly any way you look at it. We did poorly. But it is clear that preparedness matters. Getting prepared helped countries reduce the mortality caused by the pandemic. And that's really important because when we're talking to political leaders who are looking for places to cut, they may be tempted to cut preparedness because they think, well, it didn't really matter anyway. That didn't affect how places were harmed by the pandemic. We're talking about equity today, and I want to say that this is incredibly important. If there is no other topic to talk about from pandemic preparedness, we have to talk about inequities, because when we're trying to reduce our vulnerabilities to infectious disease threats, we should start with the points of our greatest vulnerabilities. Go to the places and the populations that we think are most vulnerable as a top priority. And this is made harder by the incredible inequities that we see happen in these events in terms of global inequities, right? So we know quite clearly that when pandemics happen, not all countries have access to the same tools. And what I'm showing here are data. The blue in the syringes are pledges that countries made to share vaccines. And the orange is what the countries actually delivered by month. So as you can see, there's a lot more blue than there is orange, and the orange shows up quite late. You might look at this, if you weren't looking at the x-axis, you might look at this and think this is what I'm talking about here is the COVID-19 pandemic. But this is actually from the pandemic that happened before, the 2009 H1N1 influenza pandemic. So what we see very clearly is that when pandemics happen and every country is affected for itself, it means every country tries to take what it keeps what it has or tries to get what it needs. And that often means not enough for everybody. We unfortunately saw those same trends play out during COVID-19, where there were clear disparities in terms of countries' access to vaccines. And it wasn't even about money per se. Countries wishing to purchase vaccines weren't necessarily able to get them. They weren't necessarily able to get to the front of the line. What I'm showing here is that we have made a lot of progress in terms of expediting the development, the research and development about new vaccines. Certainly, COVID-19 was done in historic speed, and there are important efforts underway to make sure that when the next pandemic hits or epidemic hits, that we could do it even faster. That is incredibly important. But I think one of the things I want to point out is that it's not just about developing the new technology. It's also about making sure we have the capacity to distribute and administer and get to everyone who needs it that same technology. We talk a lot about vaccines, which is important. I can't think of a better tool to use in an infectious disease emergency than a vaccine. But it is not the only tool. And one of the things I think we don't spend enough time talking about are the inequities we saw for other global health technologies, including tests. Testing was subject to the same sort of global inequities that we saw with vaccines. In fact, the inequities in terms of how much testing countries had or had access to or were able to do, who they could test, how much testing they could afford to do, probably fueled some of the initial misperceptions about which countries were affected by COVID-19 and which ones weren't. We probably saw, a bias towards the countries that had a whole lot of tests and could do a lot of tests. One of the things I used to do when I was at Johns Hopkins was tracking global testing trends. And as you can see from these testing positivity numbers, it's all over the place. These testing positivity numbers are all over the place, not necessarily because these countries have more or less COVID infections. It's because of the denominator, that they have more or less tests to conduct. And therefore, if you're only testing the people who are very, very sick that you are pretty sure have COVID, you're going to have a very high test positivity rate. Whereas if you're like Hong Kong or Taiwan that did a whole lot more testing than they had infections, then they're always going to maintain a low testing positivity. And I think this is just an illustration of the inequities around testing, which is just yet another inequity when we're talking about access to global health technologies. Testing is my personal hobby horse, so you'll hear me talk about it a lot if you hear me talk. But I think it's something that we don't pay enough attention to and an important public health tool. There's been a lot of great progress in terms of research and development around trying to make research and development more distributed, to make sure that we are not just, pinning our hopes on a few global countries that are only located in certain parts of the world. Efforts around distributed research and development, distributed manufacturing. I think this has been an important outcome of COVID-19, and particularly on the African continent. I think there's a lot of excitement about some of the progress that's being made there. This is important not just for planning for future health emergencies, but also important for economic development. The bioeconomy drives economic development in countries, and I think this is an important positive outcome. And so I want to acknowledge that progress and offer support for continued progress, making sure that we sustain those gains and investments, not just for the purposes of making us more health secure, but also for economic development. But I do want to also stress that a lot of times we fixate on the tool and not on the capacities that are needed in order to be able to use the tool. And so when we're talking about global health technologies from vaccines, we also need to ask, do we have the operational capacities to turn that tool, that technology, that vaccine into a vaccination? And that was something that we saw countries across the world struggle with. Not just do they have the tool, but do they have the programs to not just vaccinate children, which is something that countries have been long working on doing, but vaccinating adults? And how do you do that? And that looks different. And that requires different approaches, that requires different settings, it requires different providers and different supporting materials. One of the things that we found was that in this study that one of my students who worked at the WHO did was that perhaps having routine exercises in the form of seasonal influenza vaccination programs was associated with higher vaccine coverage, in part because seasonal influenza programs vaccinate adults. And if you have practice doing that every year, perhaps then it's easier in a pandemic when you then also have to vaccinate adults. So just to kind of put a plug for, let's think about the public health capacities hand in hand with thinking about the technologies, and particularly when we're talking about equities, we can't just focus on the tools, we also have to focus on the systems. The Global Health Security Index, this is the data from 2021. It paints a relatively bleak, I mean, it is a bleak picture. There is no country that is fully prepared for a pandemic. And even if you score 100, I'm not going to tell you that you're fully prepared. I will tell you that you have a lot of the tools that we think are necessary. Doesn't mean you're going to use them. It doesn't mean you're going to use them well, but these are the tools that the global community has generally decided are important. Nobody has it all. There are a lot of gaps across the globe, a lot of gaps. The point of having an inventory like this is to show us where the gaps are and to help us prioritize where and how to fill them. This is, I think, the work that remains in thinking about global health security, and it will continue to be the work that remains, even as the global policy landscape, global funding, all sorts of things are changing. But nonetheless, we know that having these tools is necessary, even if it is not sufficient. I just wanted to tell you, just to sort of end, is that one of the things that we've been very fortunate to start working on is something called the African Health Security Index. And this is this is not the Global Health Security Index. This is a regional version of it. We are doing this because what we have found in producing the index since 2019 is that our greatest user base is on the African continent. We call them our super users. These are professionals and practitioners who reach out to us all the time. They present the data in conferences. We see them a lot. So we've engaged in a partnership with Science for Africa and some other institutions on the continent to work with practitioners on the continent in order to figure out how to make the tool more useful for their needs. But also one of the things we're exploring is whether and how to include other drivers of infectious disease risks like climate. That's not something that's well covered by the Global Health Security Index. And so by engaging with our super users, we're trying to explore whether it would be meaningful and useful to start incorporating other variables like climate-related dimensions into the Global Health Security Index. We're actively working on this now with the goal of publishing this index in 2026. One of the things I'm most excited about is it's the first time we've ever really been able to engage with users of the index in terms of producing it. And I think this is an important step for the index. It's, unfortunately one that requires resources, but it is, I think, important to make this tool more useful. So I just wanted to kind of preview that, and also happy to connect with folks who want to learn more about that effort. And I'll just end there with my thanks. And if you have, any questions, happy to have them in the discussion or even afterwards. And here's how to find us for more information about this. So thanks so much.
Thank you, Dr. Jennifer. Thank you so much for that amazing presentation and for the insights. So right now, before we move on to the third speaker for the day, we would like to once again apologize to all our participants that has been trying to join the webinar, but due to technical glitch from our end, they are unable to join the webinar. For the presentation slides, with the permission of our speakers, yes, the presentation slides will be shared to all registered participants. And also the recordings of the webinar will be made available on our YouTube channel. So right now, I would like to invite our third speaker for the day, which is Ms. Vivian Iekwazu. Certainly not the least, but we are pleased to welcome Ms. Vivian. And before I officially give her the floor to speak, I would like to read her biography. Ms. Vivian Yekazu is the Managing Director of Nigeria Health Watch, an advocate for improved health and access to service in Nigeria. She leads the strategic direction, designing health communication and advocacy campaigns for government, nonprofit, and development partners. With over 20 years in communications, our work focuses on nutrition, maternal and child health, immunization, sexual and reproductive health and rights, and health security. She played a leading role in COVID-19 crisis communication, supporting the Nigeria Center for Disease Control. Vivian holds an MSc in Global Health Policy from the London School of Hygiene and Tropical Medicine and is an African Public Health Leaders Fellow at the Center for Universal Health, Chatham House. She also has an MBA from the Gordon Institute of Business Science, University of Pretoria. Thank you very much, Mrs. Vivian, for accepting to be our speaker for this very important discussion. You now have the floor.
Thank you very much. Let me just share my screen. Fantastic. Okay, sorry, just go back to the beginning. Sorry. Okay. Okay, thank you very much, and thank you so much to Boniface and Jennifer for those really great intros. I think you've set the stage for my presentations, and it's good to hear from AMREF and also from Brown Pandemic Center some of your insights around broader, beyond just thinking of the pandemic agreement. So as Faith mentioned, I mentioned director of an organization called Nigeria Health Watch. And Nigeria Health Watch is a health communication and advocacy organization. We're primarily based in Abuja in Nigeria, but our work kind of spans broader and actually spans across the Africa region and also globally. And our global reach is influenced by the ease of communication beyond the Nigeria border. Introduce myself, I have a very strong communications background, and I know when I started and when I do a lot of the work I do, people often are wondering, what is somebody in communications working in public health? I think that is more evident now more than anything. And as much as we have health interventions, we have vaccines, it's very important that we are engaging with the end users, and that is the public. And so the work we do really engages them through various platforms, through our policy dialogues, using our social media platforms, through our websites, through our editorials, and all the other advocacy and communication tools that are available to us. And this is really, really important more than anything, because in order to influence behavior, you have to be able to reach the people that are the end of whatever intervention that you're trying to implement. So thinking about the pandemic agreement, I won't go into it in detail. I think Boniface did a really great job of providing an overview about the pandemic agreement and the context in which it was even developed in the very first place. The idea, is how do we unite nations around this common goal? And the thinking obviously around it is based on experience from the COVID-19 pandemic, where countries came together and said, we need to have a framework going forward so that we're better prepared. And also the issue of equity that I think Jennifer really, really highlighted is addressed through an agreement that countries collectively agree to. And in order to build that trust, there needs to be an element of agreement across nations and how we behave going forwards. I think the example that was shared about the distribution of vaccines is a fantastic one, as the assumption is it's not just the COVID-19 pandemic that experienced the inequity in vaccine access. We've seen it before. During the H1N1 outbreak, comparing the access to technology that many countries had was very inequitable. And for that reason, there really has been a rethink on how countries work together to collectively address outbreaks that affects everybody. I think in a way, COVID-19 was unique in that every country globally was affected simultaneously. And for that reason, the pandemic agreement really was monumentally signed in May 2025. And it really emphasized why coming together as individual countries was very important in how we agree and how we actually treat each other going forwards. Now, as I mentioned, at the essence of all this work we do, at the essence of public health, is communication. And why is that even important in the first place? Communication is, varied, and it's not just simply about, messaging or broadcasting messaging. Communication is really also about how do we build relationships? How do we reinforce trust? So looking at each of these components that are listed here, we'll explore each one and just see how every single one of them plays an important role in, when we look at pandemic preparedness, how those things are important. So looking at building of trust, why is that important in communications? When we communicate, be it even in our families, be it with friends, whoever, what it does, it creates a link. And in public health, communication builds a link between institutions and the public. Because when people feel that you're speaking to them rather than speaking at them, then they are more likely to see health and people in health authorities as allies. So for example, in Nigeria, at the very onset of the COVID-19 outbreak, the key people who were communicating to the public were government. But when we think about how is that social contract between the public and government, it's not very strong. So why should people now, after all these years, listen to government? And that was a very tricky balance. And we saw it in many other countries where that social contract, where it wasn't very strong, there was difficulty in communicating to the public how they should take action to protect themselves and the public. So really, that link between the public and institutions is critical. There needs to be a relationship, and that is how you reinforce trust. And those relationships can't just be built in wartime, so to speak, like in an outbreak. It has to be built over generations, over years, in periods where there isn't a crisis. And this is very important because in times of crisis, it's very difficult to quickly build up that relationship. What else? It's very important that people don't just know what decisions are being made. How do you understand why those decisions are made in the first place? So really clear communications really helps convey, health policies. It ensures that, the public interest is taken into account. And it's not just driven by politics, but by profits, or not just driven by politics, but also for the best interest of the public. One thing we saw on the onset in Nigeria, there was a presidential task force on COVID-19 that was quickly put together, and that included ministers from all the different agencies. So very quickly, the government did take the lead, but included in that team were a group of scientists who led the thinking around the science around the pandemic. So we were lucky in a way in Nigeria, and I will say, because the response was not driven by politics. It was driven by the science, by the evidence that was coming through. We know that was not the case in many other countries. And when outbreaks and when the pandemic became politicized, that social contract was where that social contract was very weak, it was difficult to now get people to adhere to what they are being told. What else? It addresses fears and misinformation. Misinformation, we saw the deluge of infodemics, the excess amount of information that people had access to. And in the absence of trusted information, rumors thrive. Where there's a vacuum, often that gets filled by misinformation or incorrect information. So, good communication must anticipate that there will be misinformation, and it needs to be proactively responded to. And this means, addressing people's innate fears, not just dismissing them, but acknowledging that their fears are valid and they feel that they're being listened to. Communication is also important because it enables trust and empathy, because when people understand that you're actually thinking about their what's best for them, then that empathy enables them to make an effective response, and they do listen to what you're saying. So, communications, and when we think about the pandemic agreement, that is critical in how people even understand that countries, that nations came together, that it wasn't as, was often widely portrayed, the WHO, for example, being the one that is telling people what to do. So that communication was really important, and people even understanding how the pandemic treaty came about. So this was driven by nations, not by a singular agency. And if effective communication, it bridges the gaps between the authorities and communities. It has to be timely and delivered swiftly. So as much as we're communicating, it's also important to think about channels that can be used to convey information quickly. Looking at transparency, how open are those decision makers? How transparent are they? How much information are they revealing? And when there is any inaccuracy in information, how open are they to correcting it and explaining to the public why certain decisions were being made? So transparency is really important. And that transparency is also often driven by how much data you are actually sharing. And that data, we can think, over the last outbreak, the last pandemic, how many cases are we finding in communities? How is that data even being shared? How are people able to understand and trust in the validity of the data? Also, we have to think about how consistent our messages. If one government agency is telling people to do X and another is telling people to do Y, how are people supposed to know which one to trust? So consistency also is important to ensuring that we're conveying a unified information. Cultural sensitivities. We can't just assume that all people are all the same. All communities are not monoliths. We have to think about how we're tailoring our messages to the different contexts. I know, like in a country like Nigeria, where we have diverse languages, many of the messages were communicated using people's local dialects. And this will be the same for other countries where English or French or German or whatever it is, or Swahili, may not be people's first language. So making sure that messaging is tailored to the context helps in building that strategic trust between people. And of course, the two-way dialogue in that enabling the public to be able to answer questions and enabling a response to be given. I mentioned the presidential task force that was put together for the COVID-19 outbreak. One of the things that was very unique and different about it is every single evening, the people from the presidential task force would come on TV and would share with the Nigerian public how the outbreak was unfolding. And there we had people, journalists, who were able to now ask questions. This was actually quite unique because ordinarily, people in government in Nigeria are not often easily accessible. So those journalists were in a way able to ask questions to the politicians, decision makers, about things that maybe the public wanted to understand. And that two-way dialogue enabled ease of communication, and people were able to quickly ask questions and get them answered almost in real time, which I would say is very unique for our circumstances. So I mentioned about building trust. Building trust is really, really critical. And, trust is underpinned by how we communicate, especially in health emergencies. And, COVID-19, I think, was that reference that we always talk about, how, the deficit of trust really built an environment where misinformation was able to thrive. So we have to be cognizant that, the pandemic agreement and the success of the pandemic agreement really hinges on that public trust as well. I'll talk through why communications is really important, and I'll talk about it through the perspective of a case study we can all kind of relate to. So I'm looking back to the 2014 Ebola outbreak. Very early on, there was a lot of mistrust, and thinking through some of the issues that arose. During the Ebola outbreak, there were clinical trials that were being carried out. And given the number of cases, this was a ripe opportunity to carry out these trials in countries where there was a high Ebola incidence. So looking at Sierra Leone, Liberia, and Guinea, they faced really high numbers of Ebola cases. So during that period, some trials were carried out. And there was a lot of resistance in the community. There was a lot of suspicion about why are they suddenly carrying out trials. This is where we talk about that social contract between the government and the people, where, people don't often see the government turn up. So if they have challenges with their children's schooling or health, they don't see the government coming in, but suddenly they're now doing a clinical trial. So there was a lot of resistance in the community for those trials to take place. And, some of the hesitancy wasn't just about, it wasn't just about hesitancy. There was also a deep distrust about some of the global actors that often they see, so some of the health workers they often see, and also some of the social realities that they experience. So initially there was a bit of mistrust, and there were challenges, and a lot of these are deeply rooted in the country's history. And these things must not be, were not overlooked. And getting that level of understanding during the trials, or even thinking about when there was a vaccine, how do the researchers understand that context and understand the motives behind why people were resistant? And people were asking, are we being treated as guinea pigs? There was fear of exploitation. Even in Nigeria, when the vaccines were being rolled out in the north of Nigeria, there's a history of Pfizer trials that took place before, and there was a lot of distrust that was built in some of those communities. So it's also knowing the historical context and the trauma that some of the people may have experienced in them being resistant. So the conventional communication campaigns, just informing people about the trials, the science, were not effective. So there were needs to really, really think through, how do we make sure that you're involving the community? How do we ensure that you're using your lessons from the past? How do we ensure that you're actually embedding social science in some of the trials? So when local researchers worked close by or hand in hand with some of the clinical teams, they were able to quickly identify some of these cultural cues and understand some of their concerns, and understand why some of these shaped communities' perception. And also, they also leaned on trusted figures in communities, in many contexts in sub-Saharan Africa. Many of these trusted voices are often religious leaders and community elders, and they were also brought in to deliver some of the messages, and also to shape how the protocols for the trials were actually being implemented, and also to ensure that people consented for the trials to even take place. So acknowledging the history and understanding the context was really important. And this is a very important case when we think about future pandemics. How do we bring the community in? How do we inform them? How do we speak to them? So when we talk about the pandemic agreement, how are people in communities even understanding why this is even important? How are we bringing in other voices beyond decision makers? How are we bringing in community leaders, people that are trusted and are known? And how are we bringing them in, and they being the messengers? So it's not just about the message, we often say, it's also about the messenger. That's also often important in how we build that trust in communities. So trust, as I mentioned, is a prerequisite for any global health intervention, because trust is critical in disseminating the messages. Sorry, I've just lost my oops. Sorry, I just lost my slides. Apologies for that. Where was that? Okay, sorry. So I said trust is really important, because we have to know that in preparing for pandemics, and if there is a vaccine, that there's acceptance very quickly, because that's, for us, as we saw with COVID-19 pandemic, was the quickest way we could get out of that. So it's really crucial that public health authorities are also part of that, and also ensuring that when guidelines are issued, that you ensure adherence. So ensuring the community is carried along is really important. And this is also critical, because in order to sustain the trust, it's not automatic that everybody in communities will agree to some of these public health measures. Making sure that these are communicated and are sustained is really important in gaining that and keeping that long-term trust. So when we talk about trust, what really are we talking about? I kind of look at this around, when we think about some certain, what I say, building blocks that helps in trust. So how competent are the people who are communicating? So what is the ability of the institutions and the leaders to do their job effectively? Often this is taken for granted. We often know that the people who are doing the research, as we gave the example of clinical trials, we often know that the public health leaders who are leading the messaging are competent and have the ability and are informed. So this enables them to do their job effectively. So for example, during a pandemic, it's easy to deliver vaccines, but how are we coordinating that in communities? How are we coordinating the response? How are we sharing information accurately? Is this being done in a timely method? If people don't believe that you're capable, then why should they follow your guidance? Even if you have the best of intentions. So, with the pandemic agreement, for example, we have to ensure that the people who are conveying the message are fully aware of what is contained in that pandemic agreement, as we just saw Boniface take us through. The people also communicating have to have integrity. That's almost given. Integrity is also about honesty. It's about also consistency. So are the rules of the agreement being applied fairly? Are leaders being transparent about what they know and what they don't know? During the pandemic, the guidance often changed. And people questioned, oh, last week we were told to wear masks. This week we're told to do something else. How do you ensure that, as, for example, you get new evidence, you get information, that people understand that science is on a continuum, and the people who are conveying that information have the integrity to do it, but also help communicate why it's also important. So being transparent, sharing what you know and what you don't know at any particular time is really important, because when people feel that they're being misled, then they're going to stop listening. And even if leaders have the best of intentions, and one leader says one thing and another says another, that inconsistency can often lead to mistrust. And of course, we think about how benevolent. The presumption is a lot of the guidance that people are given, and the thinking and the will behind the pandemic agreement was developed out of benevolence, learning how, through the inequity that was experienced, how do we make sure that going forwards we don't have a similar thing? So, in a sense, the institutions that are conveying the messaging, it has to be clear to the public that this is in their best interest. It's not just about, as I mentioned, competence, but people feel that the leaders genuinely care about them. Are their concerns being listened to? Are you putting the needs of the most vulnerable first? During the outbreak, the pandemic, many pregnant women did not have access to vaccines initially, because through the guidance that was given in many countries, they were left out. So there was very quickly a sense of mistrust that pregnant women should not be given the vaccine. And later on, through more research and more insights, it was now available. By then, there was a huge communication gap that had been created, and that needed to be quickly filled. And health workers, not often knowing the right information, were often the ones who were cautious and didn't always advise pregnant women, for example, appropriately. We think about transparency, something I spoke about. Transparency, is about openness. Share, as I said, what you know and what you don't know. People can often, maybe not fully forgive, but overlook where all the information is not available. But the foundation of that has to be trust. And of course, think about our participation. How much are we including people in decision-making? They're the ones who are most affected. So it could mean, are we doing community consultations, the pandemic agreement? How much are we having smaller groups in countries? How are we engaging different stakeholders? How are we ensuring that it's not just something within the health sector, but we're also expanding it to other stakeholders in education, in tech? How are they also being part of disseminating a lot of messaging on building trust? So a lot of health messaging often gets kind of stationed within the remit of the health sector, but we know that it's often a whole of society approach. So how are we making sure that other people are part of disseminating a lot of messaging? So, the trust deficit that we saw in the COVID-19 pandemic really has exposed many of the inequities, and the pandemic agreement really is that opportunity to take us to a future where any pandemic that happens, even if it's just an outbreak, that we're better prepared and there's equity at the heart of the response. So a lot of the communication and trust deficits we hope can be addressed through careful and effective communication. We saw, as Jennifer highlighted, how during H1N1 and also to COVID-19, the surplus in vaccines meant that many African countries were left out. And so during the negotiations for the economic treaty, one of the things we saw was solidarity across the African continent. The African bloc came together, negotiated en masse for what they collectively understood was in the best interest of the continent, but also broader. And that solidarity doesn't just include the African continent and how they came together. We know the next aspect is the negotiation for the pathogen access and benefit sharing. This has been the most contentious part of the agreement. So going forward, how that is now negotiated through the lens of equity will be really, really important. Because, you know, a lot of the diplomats that negotiated to ensure that the pandemic agreement was concluded, really had to work through their governments. But we have to also think how much were citizens engaged at that point, because ultimately this was developed to serve citizens more than anything. One thing I was thinking when I was putting this presentation together, there has been a lot of misinformation around the pandemic agreement itself. And, you know, obviously you don't want to, in my search, you don't want to reinforce a lot of that misinformation, but there has been a lot of misinformation. And I think in responding and in communicating and in building trust, we have to also listen out to many of those voices on the different social media platforms that are also sharing an alternative reality or sharing alternative information about the pandemic agreement. How much are countries, knowing that the pandemic agreement was agreed across the nations that negotiate the pandemic, how much are those individual countries communicating with their individual countries? Let it not be an agreement that is assumed to have been enforced or forced upon communities or countries through a singular agency, the WHO. The WHO is made up of member states. So how are individual member states communicating how that agreement was even developed and what it even means for them? So, you know, because when we think about one of the critical parts of the agreement that was very contentious, which is the PAPS section, the reason for the disagreements or why that was very difficult is because countries have their individual self-interest. And what people have to understand is, you know, the premise of it is when there's a research, when there's new evidence in any pandemic, that the products from that evidence, the products from that research has to be equitably shared. And this has to be the lens through which we frame the discussions around equity and fairness. And, you know, the communicating what the pandemic agreement promises has to be clear in that we don't ever want to be in a situation where countries are left out from not just the vaccines, as we talked about, but also the diagnostics. How are we ensuring that testing is available? How are we ensure that if there are treatments that are available, that there's equity and everybody is able to come out of the pandemic or whatever it is at the same time, and no country is left behind, as we always say about health. So how do we now take these lessons and how do we take these findings and how do we go forwards from here? So we have to ensure that we embed any communications about the pandemic and any frameworks through a risk communication engagement framework. This is not just something we do afterwards. This has to be integrated into everything we do in the communication. So in any health emergency plan, we have to have clear strategies on how we're communicating. This has to be reflected in training. This has to be reflected in how we allocate budget to the training. Because this real-time communication, this two-way communication is really important, especially in the context of a health emergency. How are we tapping in to ensure that we prevent misinformation? Misinformation is not something we can completely prevent, but we have to be cognizant of when we're not communicating, that gap now gets filled by misinformation. We have to prioritize the two-way communication stream. It's not just about disseminating information and sharing insights or information with people. We have to ensure that there is a feedback mechanism that people can use to respond. And if they have questions or queries, that there are people there to respond to some of those, because we have to ensure that we listen out to some of the concerns that people have. How are we ensuring that the feedback from policies is being integrated? How are we using various platforms? How are we using other communication platforms, events, town halls? How are we ensuring that above the line media, radio, print, all of them, how is the public being effectively engaged? Because all of these feeds up to how the message is disseminated. Media, I mentioned, media is really, really critical. So investing not just in national radio, but looking grassroots, how do people get their information? Tapping into those various media outlets that people have access to. Monitoring, how is trust being monitored? Is there a way we can even monitor trust? Is there a way that you can develop a trust index? This is not something that's often easy to do. I know as an organization, something we're looking to understand whether there's a trust index we can develop around health, because we see the vaccine hesitancy, we see miscommunication around sexual reproductive health issues. Is there a way we can understand the role of trust and how do we measure how trust evolves? Because trust, we can almost say it's not static. Trust can also be on a continuum. And how is trust changing depending on how people are being communicated to? And I think finally, transparency. Transparency is critical. In the next stage of the renegotiations, how are we ensuring that equity is part of the commitments that people are factoring in? The PAP system, if we get it right, will make sure that all countries are able to benefit from all the products, from the research that's carried out, or all the insights that are gathered when we have outbreaks. This transparency is really key because ultimately we have to make sure that every single member state is accountable to the individual citizens, because ultimately they are at the center of responding to any pandemics. And I think for me, finally, we don't want to risk what we saw during the COVID-19 outbreak. We saw the large number of deaths that resolved. We know that the next pandemic is not if, but it's when. And in order to respond effectively across countries, we have to be ready. And all countries have to have access to whatever countermeasures are available. And I think for us and for me, that is the foundation through which the pandemic agreement was negotiated. And that is the foundation through which we all collectively, I think as a society, respond to any outbreak going forwards. So thank you, and happy to address any questions or issues that come up.
Thank you very much, Mrs. Ghebreyesus, for that beautiful presentation, highlighting the often overlooked but vital role of communication in the trust of health preparedness. You mentioned a few things and which I would like to re-emphasize. You mentioned that strategic communication involves timely information, transparency, consistency, cultural, and two-way dialogue. And you also mentioned that for us to build block of trust, there has to be participation, there has to also be transparency, benevolence, integrity, and competence. So those were beautiful insights. Thank you so much. And thank you to all our speakers, Mr. Boniface, Dr. Jennifer Nozo, Mrs. Vivian Ghebreyesus. So right now we'll be moving on to the Q&A session and also a open discussion segment where we'll be giving a few of our participants the opportunity to give their contributions. So now moving on to the question and answer, we have a few questions here. And so the first question is, given that there would never be equity in the world, should Africa not focus and prioritize surveillance instead of depending on control and looking for vaccines she may never get late or never get? So I think this goes to either of our speakers, probably Mr. Boniface or Dr. Jennifer. Thank you.
I can start. In terms of surveillance, I mean, I think it all flows from surveillance. We need surveillance to understand what is happening. We need surveillance for research and development efforts. We need surveillance to know where the tools need to be and where to apply them. So I think surveillance is that fundamental, it's that sort of the base of the pyramid, if you will, of thinking about interventions. You can't make good decisions unless you have information to support those decisions. And I think the surveillance piece is an underappreciated aspect of that. So I would say, yes, that is really important. I think the problem is sometimes we are asked to kind of pick which one is important. We really need a lot of these efforts, not just one piece. But I will say, if you only have a technology like a vaccine and you don't have the surveillance to guide their use or to monitor their impact, I think it's going to be very hard to reap the benefits that those tools would otherwise offer.
Thank you for that. I don't know if Mrs. Vivian has something to contribute.
Yeah, I think I'll just add that, surveillance is not mutually exclusive. I think collective surveillance, not just across singular countries, but surveillance has to be across borders. And as much as the African country was left behind, I think what we need is much stronger surveillance systems across our individual countries in order to not just COVID-19, but we know as a continent, we are plagued with so many other outbreaks. So, surveillance has to be in a continuum, and we have to build the capacity to do that better more than anything.
All right, thank you so much. So right now we will be moving on to the next question, which is, I think is for Mrs. Ghebreyesus. It says, the treaties are the issues for the success of the treaty, trust even in the truth of the transparency, and who is transmitting the truth?
Who is transmitting the truth? Interesting question. I think what I would say to that is when you say transmitting the truth, I think when I'm about to think about, I'm assuming the question is about the pandemic agreement. I mentioned competence as being one of the critical factors. So we would all assume that the people who are transmitting the information are competent, are qualified enough to transmit the information. In the same way, let me give an example. If you go to your doctor, your assumption is when you go to your doctor, you're going to your doctor because they have the training, they have the expertise, and they have the experience in disseminating medical information or giving you diagnosis for whatever illness you have. So in the same way, I'll say for the pandemic agreement, the people transmitting or actually developing the pandemic agreement have the expertise and knowledge and experience in doing those things. So when we talk about the truth, I would lean on people who have the expertise and experience to even do the negotiations in the first place. I hope I answered that in line with what the person was asking.
All right,
Yeah.
thank you for that. We also have 2 more questions. Okay, so it says, I guess it's also for you. How do you trust the stakeholders involved in the fighting against pandemic when issues surrounding infections are not made open? The masses are kept in the dark for the real cause of it. An example is COVID-19.
That goes back to what I just mentioned about trusting in the decision makers. We have to understand that the people who are disseminating the information at the foundation of what they're doing is based on what's best for the community. People have to trust in the science, I have to say. I think one thing we saw during the outbreak is people's poor understanding sometimes, but also lack of trust in the very science that for many years, generations, decades has guided our public health. I think of vaccines. I mean, many people will never be able to, many people won't understand what it means to have polio. Why? Because most of us had the polio vaccine. In Nigeria currently, we were able to stop wild polio virus in 2020. We were certified wild polio virus free. However, we still have cases of vaccine-derived polio virus. And that's as a result of children who have not been vaccinated. So I think people have to go back to understanding what is the role of some of these public health interventions. Vaccines have saved millions of lives. Had we not had vaccines, we would still have illnesses like smallpox. We have outbreaks of measles now. The Lancet report came out a few days ago that showed that we're rolling back on some of the gains we have made in stopping some of these very vaccine preventable illnesses. So what I would say is we have to go back to people understanding and trusting in the science, and understanding that a lot of these things are not conspiracy. They're not conspiracies that politicians or whoever are trying to harm. The ultimate aim is to do good. And that, I would say, is at the center of any public health intervention, is to do good, not to do any harm. So I think people just have to understand the science, and also hopefully the communicators or people who are in the place to communicate information are able to build that trust wherever people are, in communities or in cities or wherever they are.
Thank you for that. I don't know if Dr. Jennifer has something to contribute to that before we move on to the last question.
Not much. Next question, maybe.
Okay. So moving on to the last question, we have, how can we convince the populace to trust vaccines rolled out during pandemic when they have had varying experience on the efficacy of these vaccines?
Jennifer, do you want to take that from your perspective? I think I've answered it in quite a few ways. Maybe you can also share your perspective on that, building trust. Thanks.
Yeah. First of all, I want to put a plug in for, I think we in public health need to study this better. And not, I think we sometimes use trust as a catch-all for all the things that are hard that we can't do. And sometimes we do things in the name of restoring trust that aren't quite as evidence-based as it needs to be. And so just to plug, to echo Vivian's earlier comments about embedding the social sciences in the trial design. I mean, there are real disciplines that study how to do this, including a question of whether trust is a necessary ingredient or if it is the outcome of a process, the result of effective government interventions in people's lives. So I think there are some questions there. I will just say, one kind of warning I would say is setting out to convince people is probably not going to work. So people don't like to be told what to do. They do like to be heard. They do like to be understood. They do like to have their concerns addressed and their questions answered. And I think we have sufficient evidence to show that, and Vivian touched on this as well, about the importance of listening to people and to understanding what their concerns are. I would also say, and I'm viewing this now from the lens of the United States, where we are entering completely unprecedented waters in terms of vaccine policies as a result of new U.S. leadership. And I think there is a lot of attempt to use challenges that are specific to COVID-19 and COVID-19 vaccines and apply them to vaccines in general. And it just is not the same. There remains high levels of support for routine childhood immunizations that are different than COVID-19 vaccines. Doesn't mean that there aren't challenges with childhood immunizations. It doesn't mean that there aren't concerns about rising distrust in childhood immunizations and a need to try to overcome that distrust. But I do think we have to be very careful about how we talk about trust and not want to kind of taint all vaccines in general, because I do think it is a very different conversation depending on what kinds of vaccines you're talking about. So anyway, just to say, and I'll just say one more small anecdote when it comes to COVID-19. I mean, I have learned a few things in just talking to people, particularly adults, about the vaccines, and I've learned two things matter. Adults are afraid of needles, and adults don't like side effects. So those factors may have nothing to do with the trust of the vaccines. Those may just be other things that we should think about in the design of future vaccines. When you launch a new product, you often think about what the market wants and people's preferences are relevant. Doesn't mean that the science will work in our favor to make it such that we can give people their preferences, but it also, I think, means that we should pay attention to what people's preferences are and see if those can be incorporated into the design of future vaccines.
Thank you for that, ma'am. So right now, we would like to give a participant the opportunity to unmute and give his contribution. So if you have any contribution, kindly use the raise of hand icon. And if in the absence of none, we would proceed to closing this session. So we really want to thank our distinguished speakers once again for their powerful contributions. It was really a great one. And to everyone that joined this important conversation, we really say thank you. Also, I would like to once again apologize to all our participants that had difficulties joining this webinar session. And to everyone that was unable to join, we sincerely do apologize for the technical glitch. So to the insights shared today, they underscore the urgency for collective equitable action in global health and Africa's critical role in shaping that. So the recordings once again will be uploaded on our YouTube channel, and certificates of participation will be shared to all participants that filled the link that was shared in the chat box earlier on. So the link will also be reshared. Kindly fill in the link in order for us to have your name and your email address. So right now, before we close, I would like to highlight a few activities from GET Consortium. We have the 11th Africa Conference on One Health and Biosecurity coming up, which will be held on November 5th to 7th, 2025 in Lagos, Nigeria. And the theme of focus is artificial intelligence and biosecurity, governance, opportunities, and risk for Africans. So this is going to be a high-level gathering, which will bring together researchers, policymakers, health professionals, and stakeholders in the field at the intersection of biosecurity, climate change, artificial intelligence, conflict, and sustainable development in Africa. So abstract submission is open until the 30th of July 2025. Registration is also open, and we are open to partnership opportunities. You can check that via our website at www.getafrica.org. Also, we also have the GET Journal of Biosecurity and One Health. We are currently accepting manuscripts. Please note that publishing on GET Journal of Biosecurity and One Health is absolutely free. So we welcome original research, reviews, policy briefs, and articles, papers that advance One Health agenda and biosecurity, especially in the African space. Kindly visit www.getjournal.org for more information and guidelines on how to proceed to your submission. So thank you so much for joining. We've come to the end of the webinar. Thank you to our speakers. Thank you for your time. So we encourage you to stay connected with us through our website and our social media platforms at GET Consortium. And we look forward to collaborating with you in future webinars. So thank you so much. See you in the next edition. By July, the topic will be communicated via all our communication platforms. Thank you so much, and bye. Thank you, Dr. Jennifer. Thank you, Mrs. Iekwazu. Thank you so much. Bye.